All right, so I think we're going to go ahead and get started. So thank you everybody for being here. Thank you for joining us today. Today's webcast, Effective Response to Chemical Disaster, Leadership, Communication, and Lessons Learned from East Palestine, Ohio, is being presented by the New York State Department of Health and the Institute for Disaster Mental Health at SUNY New Paltz. I am Andrew O'Mara, the Program Manager for the Institute for Disaster Mental Health, and I will be moderating today's event. In addition to our presenters, I am joined today by the Institute for Disaster Mental Health's Operation Manager, Chrissy Lawler, who will be assisting with today's presentation. Each year, the Institute for Disaster Mental Health and the New York State Department of Health partner to bring you this web-based training, focusing on various aspects of disaster response and recovery. This year marks the 11th year that this webcast has been offered through this partnership, with around 300 participants having registered for the event this year. Today, we will be continuing to examine the unique aspects of different types of disasters, with our topic for this year focusing specifically on chemical disasters. While not often as thought about as some other types of disasters, chemical disasters often pose unique challenges in how to appropriately respond and address the needs of the impacted community when compared to other types of disasters, some of which we have discussed in previous webcasts. Chemical disasters can also have long-lasting impacts on communities and individuals, complicating the long-term recovery efforts and raising concerns about the potential for unseen health impacts. Over the next 90 minutes, we will hear from about some of the intricacies inherent in responding to chemical disasters and touch on some of the unique impacts that these types of disasters can have on health systems. To help ground our discussion and provide a real-world example of this type of disaster, we will be hearing from two of our panelists who were involved in the recovery efforts following a major chemical disaster that occurred just over 2 years ago. To help guide and frame this discussion, we are joined today by our panelists, Dr. David Heslop, Barbara Thomas, and Emily Probst. Dr. Heslop is joining us all the way from Australia today, where he serves as Associate Professor at the University of New South Wales in Sydney, Australia, as well as serving as the chair of the Chemical, Biological, Radiological, and Nuclear Special Interest Group at the World Association for Disaster and Emergency Medicine. Barbara Thomas and Emily Probst are joining us today from Ohio, where they both serve the American Red Cross of Northern Ohio. Barbara and Emily were both involved in the on-the-ground recovery efforts following the East Palestine, Ohio train derailment and chemical spill in February of 2023, and will share some insights into their experience on the ground during this chemical disaster. We're very excited to have you all with us here today. Just to cover a little bit of housekeeping before we go ahead and get started, we will save some time at the end to address any questions. However, please feel free to put any questions you might have throughout the presentation into the Q&A feature here on Zoom. These questions will either be answered in the presentation verbally, or we do also have a live answer option where we can type out answers as well. If you have any other issues during the event, please also utilize our chat function in order to get in touch with our team, who will attempt to address our issues the best we can. We're also going to be recording today's webcast, and the recording will be available to watch on the Department of Health Learning Management System later on this week. I also did see a question, and I'm seeing some things come in here in the Q&A. We are going to be taking the rostering for today's presentation as evidence that you did attend. So please do make sure to put your name, if it's not the name of your of the account that you joined Zoom with today, please do to make sure to put your name and your organization in the chat so we can make sure to capture that information as well. To start off our presentation this afternoon, we'll first hear from Dr. David Heslop. Dr. Heslop is an associate professor at the School of Population Health at UNSW Sydney and is a clinically active GP and occupational and environmental physician. He is deployed as a medical officer to a wide variety of medical and humanitarian assistance environments and is a chemical, biological, radiological, nuclear, and explosives medicine expert. He is also specialized in the risks and health systems required for deploying to austere and high-risk work environments. Dr. Heslop continues to provide clinical and technical specialist advice and support to the Australian and international militaries and industrial and large organizational partners in his specialist medical advisory role. His research focuses on developing collaborative research opportunities between military industry using models of health systems and human behavior under emergency and crisis conditions, as well as changing conditions such as climate change and resource scarcity. The health system optimization using diverse methods, including qualitative and mixed methods approaches, such as digital twins, AI integrated modeling, and traditional agent-based modeling and simulations. Dr. Heslop will examine the importance of leadership, command control, and most importantly, effective communication, also known as C3, between authorities, victims, and others during the early stages of disaster response. He will also touch on the implications of ineffective C3 during chemical events, as well as provide evidence supporting how to mitigate system failures with a focus on addressing the holistic needs of both the individual victims and the responders. Dr. Heslop, the floor is yours.
All right. Thanks very much, everybody. Thank you, Andrew and Chrissy, for having me. It's a pleasure and an honor to be here, and also to my co-presenters, Barbara and Emily. I think my presentation will lead really nicely into yours, so it's a nice order. I'm just going to share my screen for everybody, and we'll get moving. So bear with me while I do that correctly. Yes, share. And can you just confirm if you can see that?
Yeah, you're all good.
You can see the slide rather than the present mode, is that right?
We see the present mode.
All right, one moment.
It was the slide just a second ago. There we go. Now it's just a slide.
Okay. Excellent. Thank you. I'll just make sure it's right. So again, thanks for everyone for having me. I think my introduction kind of covers most of the things. I'm a clinically active researcher in the area of chemical, biological, and radiological and nuclear defence. I've worked with the Australian Defence Force as a senior medical officer in our frontline response capacity. It's very similar to many of the capabilities that you have in the United States. Today I'm going to talk about essentially research activities that are have dovetailed very neatly with a lot of the work that I've done both domestically here in Australia and internationally in this area, and touch on the issue of human behaviour and how to respond to human behaviour, both in responders and also in victims or those who are affected by significant events. And I'll focus on chemical events because I think that has, as Andrew introduced, unique features compared to other types of events like biological, pandemic, and radiological. The kind of chemical events which we have seen over the last, say, 50 years around the world have been quite diverse. So some of those internationally which have drawn our attention are shown here, ranging from deliberate attacks through to mass casualty events, which some of you may recall, like Jonestown, for example, and the military environments through to terrorist events. Some of the events, these chemical events, have been misadventures. I would call the Moscow theatre siege a misadventure in terms of a chemical event relating to impacts of probably a poorly thought out operation. And I'll quickly touch on some of the key aspects of a select number of these particular events. You will have recalled over the past few years, we've had events in the UK, particularly the Salisbury Novichok attacks. These were very public events. They were resulting in a large multi-agency response and international impacts and outrage. These also had a significant impact on the local community in terms of behaviour, in terms of the fear that it generated, in terms of the operational response required and the disruption on those communities. Novichok, as you know, is like a nerve agent. There have been many other nerve agent events, some of them alleged and proven, and they have been, for example, from Syria through to Iraq many years ago, and smaller scale events such as Kuala Lumpur in the past 10 years. And all of these have a similar pattern where there's a large interest in the community, there's an impact on the community. Similarly, other events like Bhopal, for example, which is an industrial disaster, again, a huge impact from a mortality and morbidity effect, but a huge, a larger, broader effect on the community, which is persistent even now, many decades later. Other events which have occurred, which really haven't featured it so prominently within the mind of the community, have been quite common. At UNSW, we've done a series of epidemiological studies on the frequency of chemical events around the world. And in fact, they occur frequently. There are at least a number every week, some of which are quite large, and often are not substantially reported into the media, that most of them being accidental is a bad word, but accidental in their impact. So they are quite common, and in fact, chemical events impact the community quite frequently, more than you might be realize. So what happens when there's a chemical event in the vicinity of an individual or group of people, and the individuals are aware of it, is that you have a combination of voluntary and involuntary impacts. And the voluntary impacts really come down to behavior. There's this, when we say voluntary, I mean in the control of somebody, somebody could potentially modify those behaviors. Whereas, and some people have a lot of trouble voluntarily modifying, but we call them voluntary. Things like shock and fear, panic and confusion and denial, or even a thing called underreaction, which is essentially a reaction to an event occurring where there is a cognitive process that unfolds where someone is not willing to accept that something needs to happen, or they need to act, or that things will just be okay and it will all go well from now on. And these are typical, almost stereotypical behaviors in humans in the face of a significant threat. The difference with chemical threats is there is the element of the unknown, and there's an element of uncertainty in terms of what will happen to an individual. Then there's also a question of horror and sort of fear of horrific injury that may be permanent, and that augments and amplifies these kind of responses. But it's this suite of responses which is consistent. Involuntary reactions really relate to fight and flight reactions. They're much, of course, mediated by sort of more ancient parts of our physiological and behavioral response repertoire, sort of midbrain responses. These also can extend to freezing behavior, where people are incapable of moving even if they wish to, and involuntary reflexes, automatisms, and the direct effects of chemical exposure on the body. And these might be sort of reflexes or, impacts on the nervous system, which mean that there's an inability to respond as normal, or things are different. And so the combination of these things render some individuals quite paralyzed almost, and unable to move and do what they need to do, and others to display quite bizarre and unusual behaviors. There's examples throughout the literature of, for example, the Costa Concordia disaster, where there was a sinking ship. People were essentially did nothing. They waited for the ship almost to sink before they could move, and they were unable to move. Other people ran around aimlessly, apparently in a sort of almost like an automatism. So there's really good evidence that a lot of people, upwards of maybe 80% of people, have some kind of impact like this on their behavior. So why does this occur? What factors influence it? Well, part of it is about sort of perceptions of risk, and there are people's own biases. There's a rapid onset of fear and uncertainty, and assumptions are made. Assumptions can be convenient. They feed into this idea of, inertia, and people being unable to actually make a decision. And often it's a lack of knowledge or appreciation of the implications of what they're seeing unfold. We saw this in the port of Aqaba. So the port of Aqaba had a major chlorine leak. You can look it up, the video on YouTube, to see this, where a container was dropped and exploded, and the chlorine cloud expanded. And that was a visible cloud, a particular chemical incident where it was visible, and people on the dock were either running away or essentially stood still and were exposed. And it really was consistent with sort of the range of behaviours that were seen. And unfortunately, a large number of individuals died in that particular event. So there's quite a significant variation across populations of sort of the tools that people need to assess a situation. And if it's a chemical disaster where there's invisible threat, that becomes the fear is augmented and there's an uncertainty about where hazard exists. There are social and psychological factors. As I mentioned, they link into sort of knowledge, but also there's these sort of upbringing, background, how you view the world, how you view others, and how that interacts quite strongly on sort of how you might respond. So you may have an innate requirement to help other people that's in your philosophy, and that will change how you actually behave after a disaster, and that's quite varied. And then cognitive factors, including memory, like losing the ability to even access memory due to fear and uncertainty, and your training and readiness, so to speak. So some of the things that can modify this are peer influence, group cohesion, leadership. Stigma is another one. So the stigma of being exposed, the stigma of being injured, and the stigma of a chemical event per se. These really can modify behaviours strongly, so lead people who would otherwise help to not help and leave. There's also the idea of the fear of contamination. What does that mean? And potentially contaminating others in the community or your loved ones. And then the expectations of services. So some people don't realise that services may be quite delayed and they need to respond. They need to help themselves and others. Otherwise, they're going to essentially be too late by the time these services arrive. And that's quite common in a big city like New York, for example, or in Sydney. Getting hazardous material services to an incident site in sufficient numbers to help a large number of people is actually going to take a long time. And so responding yourself initially is probably one of the biggest predictors of survival in many circumstances. And part of this is a question of performance of systems, as I've just mentioned, but another one is communication. The other issue with expectations of services are critical services like decontamination, which I'll touch on this talk. So some of the challenges, briefly, information overload, information void, and message consistency. All of these things are really difficult to achieve when you don't have your emergency services on site. So there's a lot of he said, she said, and misconceptions. Mental health, disability, and language barriers really feed into some of the issues with behaviour post-incident. And then there's these hot button groups like babies, pregnant women, the disabled, those people who can't help themselves, and the horror of seeing somebody who is essentially unable to be helped, but really have done nothing, and they're someone who cannot ever help themselves and they get harmed. And that's a very big moral challenge for people and expectations about government and who actually helps then feed into that, and it becomes a vicious cycle. There is also a big difference between the interactions between emergency response services and the public. Priorities of first responders differ substantially from the priorities of casualties. I'm going to touch on a study which just really outlines this particular dynamic. Essentially, casualties and bystanders, people involved in the actual exposure event, expect totally different things to what first responders need to do. Managing that discrepancy often results in a lot of angst if it's not done well. And then if expectations aren't met, you end up with potentially more casualties, contamination that moves around a city because people reject the response and leave, which is what has been consistently seen across multiple studies. And then the result of degraded healthcare services, follow-on impacts, loss of trust, and then moral injury amongst the actual victims, but also first responders, because the system kind of broke down and didn't anticipate the realities of human behaviour in these events. Quickly, and I'll go through this very quickly, I just outline in a study that I did with a colleague of mine, Jane Curry, who's a nurse, a disaster management specialist here in Sydney. It focused on CBRNE, which is chemical, biological, radiological, and nuclear preparedness. And it was an exercise which was put together to test capabilities locally. Decontamination was the focus from our perspective. It's an essential component of chemical exposure. If you have hazard on you, it needs to come off. How that's done is through a formalized methodology, essentially where you're removing that into a safe environment and that no longer can expose others. It's a process, it's a validated process, but it's often problematic for everyone to understand, get their head around. It requires a lot of communication and compliance from victims, often victims who are themselves either psychologically or physically traumatized or cannot really help themselves. And designing systems to be able to manage all of those kind of casualties is actually quite hard. So these recent CBRN events all characterized by a need for decontamination. These were either well managed or not well managed, and you may have seen pictures in the news reports of people being decontaminated through very ad hoc methodologies, such as hosing down, people just lying on the ground, water being poured over them, for example, and that may or may not be the most effective way to decontaminate, leading to, if it's ineffective, a whole lot of questions in victims and others observing that about competence and willingness to trust. So as I've mentioned, it's previously validated method, but very important. It's actually a medical intervention and will help people to survive a exposure most effectively. And just to highlight the most important step in decontamination, and this has been shown through the PRISM studies in the UK and various other evidence bases, the removal of clothes. Contaminated clothes achieves about a 90% reduction in hazard, so it's about 90% effective decontamination. And then the remaining 10% is comprised of either a very cursory wipe down or wash. Essentially, that takes another 9%. So hasty field decontamination comprising of clothes off and then a hasty wash down or wipe down, dry decontamination, depending on what you're dealing with, will produce about a 99% effectiveness. Communicating that to bystanders who expect a full wash down in hot water is actually quite challenging, and you need to be clear across all language groups and abilities that that's the right thing to do, and that's hard work. So this is our old school decontamination. Pretty intimidating. I think psychologically, a lot of people would find that very challenging environment to work in. This is First World War. These days, we have a different approach. This is US guidelines from the Edgewood Center, Chemical Center. You can see crowds of people leaving a metro station on the top, and you can see that they're going through a thing called a ladder pipe system, which is fire appliances or trucks with a ladder across it and then a shower. You can just see that in the middle there, and they come through that. And that's an expedient process, but you can imagine asking people to disrobe, remove their clothing, and then go through a ladder pipe system will actually produce approximately, in most people, a 99% reduction in hazard. That just needs to be communicated well. I use the word just, that's an assumption. That needs to be communicated well, otherwise people will reject it and they will move away. If they don't like what they see here in this diagram, they will leave. They will go back to the subway and they'll go elsewhere. They'll catch an Uber or a taxi. They'll go home and they will be contaminated. And this is exactly what we found in a number of studies, our study included, that when people who are involved in this don't have the information they need, they will do things which are very dangerous to the community, like go home and contaminate their house, contaminate transport, and contaminate others, leading to more hazard and more issues to deal with for responders. So I think this is a very important topic to deal with, what people choose or choose not to do. This is the kind of setup we see in Sydney. It's very similar internationally. It's very, very much standard. Again, quite intimidating if you've never seen something like this before, with people who are very impersonal with a lot of protective equipment. It's hard for people to see that and feel like they can be involved. Other kinds of things which might be, again, intimidating for people to actually have to deal with. This is a vehicle decontamination system. Again, it has a lot of instructions. It's difficult to understand. It's got all these flashing lights. How do you interact with this? And you can walk people through this. For example, you can see there's a person in the mist there down below. So vehicle decontamination can actually be used as ladder pipe as well. So there are sort of options, but this is a very specific setup. So the exercise was a combination of a number of exercises, and it was part of our counterterrorism capabilities here. And the idea was we wanted to understand how we could manage contaminated casualties. And the aim was to look for policy. So we weren't particularly interested in the effectiveness of decontamination. We were interested in the effectiveness of the system per se. And what you did is essentially survey participants after they'd done this exercise. And we used essentially a standardized survey tool that had been modified for purpose. In the exercise, we had a number of casualties, and we used a chemical agent which was very similar, shockingly similar, in fact, to mustard. And mustard is a persistent chemical agent that has an odor, and but also is difficult to decontaminate. And the chemical agent was exposed to a number of people on one of our suburban trains on our network. And then they were presenting to a major hospital nearby to that exposure with moderate symptoms. But some of whom, however, were actually quite severely injured with the triage scale of 1 or 2. What we found is that there was quite significant differences in the kind of findings or comments that were being made about how the system worked from different types of people involved in the event. This is how many responses we got in terms of themes and codes. More in sort of relevant is this table, which shows the percentage distribution. I'll present 2 slides in 2 different ways, which are quite instructive. Firstly, that shows that the different types of groups of people who were involved, disaggregated into those groups, and then the major themes and the percentage weighting or contribution of those themes by disaggregated by those different groups. And what you see here, this is the percentage looking down each theme, and next I'll show you the percentage moving across across each group, because they showed slightly different things. What you see here is that casualties by far responded more. There were more casualties than first responders. That's typical. But what you see is these different patterns. So unsurprisingly, exercise control was interested in command and control more. So we'll set that to one side. But what we do see is that there's, in fact, a much more of a focus amongst clinical personnel and other non-clinical personnel in terms of their interest in training and preparedness and somewhat to command and control and other administrative functions. And this is typical. They're really not as interested in things like communication, for example, which was communication between themselves and also victims. And this really bore itself out. By contrast, the casualties were very, very interested in communication. In fact, a lot of their comments were about that. And that then linked within the thematic analysis quite strongly to this idea of compliance, but also training, preparedness, and clinical competence. So, for example, some specific examples, casualties were saying people were getting they weren't getting the information they needed, and they were stuck out the front of the emergency department. I got upset. No one was communicating with me. I didn't know what to do. I was scared. I just wanted to leave and go home. This kind of dynamic repeats itself again and again. This study, other studies by UK Health Protection Agency and NATO, public agencies in Europe, in the United States. I know anecdotally, I've spoken with many first responders. They say this is a dynamic that emerges. The interests of first responders differ quite substantially to the interest of casualties, and there's a mismatch, and that leads to risk, significant risk, and consequences in terms of behaviour. So just a neat small study that demonstrates that, yes, there seems to be a focus that's quite different, and that casualties are actually looking for leadership. They're looking for information, and then they're very keen to comply if they understand. So just to bring it together, casualties felt that there was a communication breakdown. Due to that, there were potentially unsafe events that drew into question the competence of the responders, and some care gaps that really upset people. That, in their mind, was interpreted as poor command and control. Non-clinicians and clinicians really felt that resource deficiencies, training and preparedness were the focus for them. So they cared more about the fact that there wasn't enough throughput capacity in the decontamination line, not realizing that by focusing on that potentially and worrying about that during the event, they were perhaps missing the point that the people that they needed to manage much more intensively in terms of compliance and giving them information to allow them to do what they wanted them to do. And I won't discuss the exercise controllers. So as I said, results that are similar to that reported in the UK and Europe. Vulnerable populations seem to be not accounted for well within our response plans. This leads again to risk because you have the consequence of not accounting for those individuals and having a plan for them is that at the time of the event, you have to spend valuable time trying to deal with that. But also there's a whole lot of negative events that can unfold because no one's organized to deal with the mentally ill or somebody who's, for example, somebody might be psychotic or they might be autistic and they might have a behavioral disturbance and they're not coping, and it disrupts a lot of things that could have otherwise happened smoothly. And then the rest of the victims see that happening and it erodes confidence and causes the plan to sort of fall over. So this averaged idealized population, which for me as a modeler and simulator it is like kryptonite, you shouldn't do it. But we often do. We think that everyone will just adapt to this average idealized population, but that the reality is very different. There's quite a diverse population. Embracing that diversity and catering for it generally, in my experience, and that bears itself out in modeling and simulation as well, does much better. And you have less of these faults that emerge within the system. So unfortunately, policy doesn't match expected reality. That's not just this study, but also consistently through other studies. We are on the ground when this then manifests, it does lead to risk. And if we're going to improve the system, really it's about really scrutinizing and stress testing our policies and approaches to make sure that these things are actually properly addressed, not only within individual agencies, but across agencies using approaches to interoperability. And there's good approaches out there that can be referred to like JESIP, JESIP, UK, that deal with this quite systematically. So underlying it all, the psychosocial aspects of populations do appear to be lower on the priority list sometimes. They introduce risky assumptions. I challenge that. In conclusion, I really want to say that the evidence supports helping people to behave in ways which is going to help them survive. And so that is something which is often neglected. It's identified as a research gap in the literature as early as 2014 by the UK Public Health Association and Health Protection Agency, and really commend to you all that this is an area of focus that really should be sort of an area of focus for everyone working in the sector from now on. And I'll leave it there. Thank you.
Thank you so much, Dr. Heslop. That was a fantastic presentation. I think, we always talk about here at the Institute how ambiguity breeds anxiety. When people don't have the right kinds of information, that's the only thing that they can really focus on, right? It's getting that kind of information. I think we saw that exactly with your data there, right? The sort of disparities between the responders and the survivors. So thank you so much. I think that'll be a really helpful framework too, as we hear from our next presenters, to sort of think about how some of this C3 issues sort of play out when we talk about actual disaster responses to chemical incidences on the ground. So next we're going to hear from our other two presenters, Barbara Thomas and Emily Probst, both from the American Red Cross of Northern Ohio. Barbara Thomas is the Senior Community Disaster Program Manager in the Northern Ohio region of the American Red Cross. She's been with the Red Cross since 2016 and has served as both a volunteer and paid staff in recovery, response, and preparedness roles. Barbara works closely with volunteers and staff to meet the mission and support community resilience in response to disasters. Emily Probst is the Regional Disaster Officer in the Northern Ohio region of the American Red Cross. She has also been with the Red Cross since 2016 and has served in a wide variety of roles during her time there. Emily enjoys working with the volunteers in order to make an impact on communities across the country. Barbara and Emily will share their knowledge and experience from working on the ground with the American Red Cross following the train derailment and chemical spill that occurred in East Palestine, Ohio on February 3rd, 2023, just over 2 years ago. I think we're all eager to hear about their experience and collaborations with other responding agencies during that response and in the aftermath of the events of February 3rd, as well as their insights into some of the unique aspects of this particular response. So without further ado, I will turn it over to you, Barbara and Emily.
All right. Hello, everybody. I'm going to go ahead and share my screen as well. Okay. Can somebody confirm that they can see that?
All good.
All right, great. So welcome. Thank you for having me today and having Barb as well. We are here to talk about the East Palestine train derailment. We're going to share a few things with you before we jump in. So as Andrew mentioned, my name is Emily. I'm currently the Regional Disaster Officer. I've been with the organization for 9 years. And Barb Thomas is our Community Senior Disaster Program Manager, and she's been with the organization in a paid staff role for about 7 years. We want to take the opportunity as well today to share the Red Cross mission statement. So the American Red Cross prevents and alleviates human suffering in the face of emergencies by mobilizing the power of our volunteers and the generosity of our donors. This is something that I feel very passionate about in sharing, especially when we're in platforms like this, because without our volunteers, the Red Cross could not do what we do each and every day. We are truly reliant on them to be out in our communities and providing all the services that our generous donors provide this organization to do in being out in their communities. And so all the things that we're going to share a little bit about today are really a true team effort, but a majority done by volunteers and supported by members of our paid staff. And I just wanted to give all of our amazing volunteers a shout out. So if you're a Red Cross volunteer on this call by chance, thank you so much for being a volunteer for us. We greatly appreciate you. All right, so today we're going to be discussing the East Palestine train derailment. We are going to be discussing the Red Cross response. So we're going to talk a little bit about our sheltering response, as well as the follow-up support and what that looks like in the community and how we show up in a way for this specific disaster. All right, so some initial information on February 3rd of 2023, we received a request for support via our EMA or our Emergency Management Director in that county to support with a shelter. So the initial information that we had at that first call was that a train had derailed and it contained hazardous material. And they were discussing approximately evacuating 2,000 people at that time. That request was for a shelter, and so immediately our teams go into action and figuring out what are those next steps going to be as we get more concrete information through additional calls and follow-ups. So in that first 6 hours, we worked to mobilize our amazing volunteers, as I mentioned, to East Palestine High School that was identified as the shelter location. For this specific operation, we were really fortunate that our EMA was already working closely with community partners and had identified a space that we had already kind of been working with. So in some cases, in a Red Cross response, you're not as fortunate to already have a place lined up. And in this case, we were very fortunate to be able to get that mobilized and moving quickly. We also worked to ensure that our volunteers understood the size and scope of what they would be responding to. This was really important in this specific disaster, just due to there being hazardous chemicals, and that is something that we make sure, as any information we have with any disaster or emergency that we respond to, we want to make sure our volunteers have going into that. And no surprise, our volunteers stepped up when the community's in need, and they were mobilized and on their way. So the next step that we did is we established a leadership team, which consists of a director, an assistant director of operations, a mass care lead, a disaster program manager who supports in that geographic space, and a workforce lead. So dependent on the operation and size and scope of an emergency depends on how we stand up this leadership team and how long that leadership team stays in place versus getting switched and adapted into something else. But quickly we knew that this was going to be a larger response just based on the number of people that were evacuated. We always plan for about 10 10%, knowing that not all 10% of evacuated population shows up. It's usually less than that, but that's our estimated plan. And so it was important to make sure that we had a director who was in charge of overseeing liaison the information from what we were currently doing on the ground to our divisional and national support teams. Our AD of operations is that person who oversees all of those operational key pieces throughout that initial response. And then if that position is kept, through the ongoing response after that first 6 hours. In this case, we did keep an AD of operations in that space, knowing there was a lot of information that was moving and coming. We also had a mass care lead in this situation, knowing that the response and request was for sheltering. Specifically, that was the request of the American Red Cross initially, was that they needed a shelter partner. And so when we do sheltering, we do a wide variety of things, which I'm going to cover here shortly. But having somebody who oversees all the mass care tactics is really helpful from a Red Cross perspective to make sure that those things and those immediate needs of residents are being met. And then, as I mentioned, a disaster program manager. So we have geographic staff. In our region, we oversee 31 counties in the northern part of Ohio. One of those counties is in Monroe, Michigan. But we have a geographic staff who oversees 6 of those counties in a chapter base. And so they become a strong support mechanism as they become the supportive community liaison between our operations leads and our directors with the EMAs and other community partners on the ground. And then our workforce lead, which is our staffing lead. So this is our bread and butter of how we get people to a disaster, how we make sure those roles continue to be filled 24/7 as we continue to work through the operation and work with community partners. So our workforce lead is very important in making sure that we are successful, that we have a presence. The Red Cross, presence is a mission. That's a big part of our mission, that we are there. We are in person and we are showing up when our communities need us. And so really grateful for our workforce lead and our workforce team who helps support all of our volunteers who are working on those operations. All right, so our shelter operations, let's dig in a little bit to what that looks like. So for the East Palestine response specifically, we were open for 7 days. We did have sheltering and we also were doing feeding. So when we open a shelter where we have overnight stays, and even sometimes when we don't have overnight stays, we are doing feeding. So we're feeding 3 full meals a day on top of making sure people have snacks and other things to keep them tied over through the day. We also were providing individual disaster care support, or it can be referred to as IDC support. And this is our health services, mental health, and spiritual care teams. And Barb's going to talk a little bit about what each of those specifically means and what they do on a day-to-day basis when they're working in a shelter. And we also work on building relationships. So a big part of our job as Red Crossers when we are opening a shelter and operating is being able to build relationships with our residents that are in our shelters and really getting an understanding for what their needs are. So as we're going and talking with other community partners, our emergency management directors, we can say, these are the concerns of your residents. These are the concerns that, you may want to be addressing. And we can also take information back to them as well to give them updates on things that they may be wondering about. This was huge in this operation in making sure that people felt like they had a voice and that they were getting a good flow of information, knowing that everything took place so quickly and they didn't have a lot of information initially. And so being able to kind of ease people's minds was really, really important. I wanted to share a few photos for you. So what you're looking at right now on your screen is a typical view of a shelter dormitory. So we have military style cots that are set up throughout a gym, as well as we provide blankets for residents, and that becomes their little space where they can sleep, they can relax, they have a space to put their belongings and know, that that's their spot to essentially just be and decompress as needed. These were our feeding areas. So in the first photo on the left, you can see that's a typical Red Cross snack table that gets replenished quite frequently, in making sure that people have an opportunity to get snacks throughout the day. We're very aware not everybody works the same shift. And being mindful of what that looks like, and people's daily routines look different. And when you're in a shelter, you're surrounded by lots of different routines and different people. So making sure we have some versatility there. And then on the right-hand side, you can see, a table in the back there, but you can also see a center table, and just making sure that there is places pre-set up for people to eat a meal when feeding meals would come in, that you're not having to take that back to your cot and sit on your cot and eat. We want to make sure that you have a space where you can eat and enjoy a meal, and either chat with fellow residents or Red Crossers to just feel like you have a little bit of normalcy going on in your day. And then these are additional snack areas, like I said, that we continue to set up throughout the days and share and pivot to what residents need. It's also, I would say, based on time of day as well, making sure that we have a variety of different options. So fruits, vegetables, juices, chips, all of those things, again, to create some level of normalcy for people as they are in a Red Cross shelter, which is not their normal. All right, so for our shelter operation in the East Palestine response, information was key. And I touched on this a little bit earlier, but it really was important knowing that this short-term thing happened where they were told they had to evacuate in a short period of time due to hazardous chemicals, and not knowing what the chemicals were, when they would be able to go back home. If they had pets that they left at home, were those pets being impacted? What information did they have to make sure that we could calm their mind and ease those people's minds? They wanted to know, what's happening and when they can go back home. That's always a big question for people when they end up at a Red Cross shelter is, well, when can I leave here? Right? No one comes to a Red Cross shelter as a first option. It's usually a last resort. And so we want to make sure that we have a plan for them, that they feel confident and comfortable in knowing what that next plan might look like, even if we don't know what it looks like. Being able to communicate what we do know and what we can do to, again, ease their minds and let them know that it's being worked upon. And we worked very closely with our EMA on this response, initially meetings almost every hour, and then, every 4 hours, every 6 hours, just to kind of keep in contact between Red Cross, the EMA, making sure we're getting updates to be able to share information with residents, as well as with other community partners during this response. So we worked very closely with Salvation Army and some other community partners to make sure that when we had information, we were sharing that timely. Here you can just see some of our informational boards, and you can see how we were sharing information that was coming in at a rapid pace. So we had generalized information with phone numbers for our staff, as well as for, who we were contacting, but we also had updates that we were putting up with dates and times, so people knew if they were not there at the time of the verbal update that our mass care shelter supervisor would give, they knew they could go to this board and the most recent updates from the last verbal update would be there. Again, right, people staying in shelters have all different schedules and when they're working, where they're going, what they're doing. And so it's important to make sure that we are also providing flexibility so people who aren't there can get the information that they need. And so these poster walls and making sure that we were updating them timely really seemed to work in this specific shelter, because people were able to get the information. If they had questions, they could go to a Red Crosser and ask for follow-up on that initial information. Okay, and then next steps after our 7 days, residents were allowed to return home. It was deemed safe for them to return home by the EMAs, the fire departments, and other key partners who were involved in making that decision. On the Red Cross side of the house, we worked to close up our shelter operations, so ensuring that, you know, all of our cots are cleaned, all of our snacks are picked up, that we're leaving that community space back to the way that we found it. You know, that's always how we look at it. We want to leave it the same or better than we found it. And so making sure that we're respecting that community and kind of getting that closed up. And we did do a final in-person meeting with the EMA and partners to determine what ongoing needs might be needed from the Red Cross as our shelter was closing. So I'm going to go ahead and hand it over to Barb, and she is going to chat through kind of that next phase with us. So Barb, over to you.
Okay, nice job, Emily. That was a very good synopsis of what happened during that time frame. As you guys all know, people were scared, as our previous presenter had mentioned. People were scared and they wanted information, and that's one of the most important things with Red Cross, is that we know that, and communication is key to taking care of our community. So the next steps with this came in when the NTSB showed up. We have a national agreement with the NTSB, or the National Transportation and Emily, what was S? National and Safety Board, National Transportation and Safety Board. Sorry, guys, we have a lot of acronyms at the Red Cross. But anyhow, so we work directly with them whenever there is an incident involving transportation and fatality, or if there's this chemical spill, whatever. We will work with them to provide mental health volunteers to work with the community, to help the community continue to heal as they're working through their process of investigating what happened and coming up with final results. So they came in quickly. We worked directly with them to be advocates for the residents. They came 3 separate times to East Palestine between the time of the event and throughout the spring, where they had community meetings, which was unheard of. They used to always do these meetings in Washington. This event, they decided to come right to this community, which was really, really important to the community. And I think it really did support the community in their mental health needs, because they felt like they had somebody listening to them, and they had a piece of the pie when it came to decision making in sharing information to the NTSB. What we did at the Red Cross is we made sure that we supported by coming back at each meeting, providing snacks and beverages, but also with mental health volunteers they are volunteers. They're mental health professionals. They're certified, but they volunteer with the Red Cross when we have a need for them. And they came through and they did amazing things with these folks. So we made sure that we were there each time. Go ahead and so the mental health volunteers that we have, they're part of what Emily has already referred to as the Individual Disaster Care Team, or IDC. That team is comprised of mental health services, and disaster spiritual care. Mental health, we'll start with health services. Good job, Emily. Health services, we do things like replacement of medications and durable medical equipment. We advocate for the client with the doctor or the pharmacy to make sure that they can get their replacement medications as needed. And we provide health guidance and referrals as needed throughout the community. Disaster mental health, we provide short-term counseling to clients in distress. We talk about normalizing behaviors. We talk about, it's okay for you to feel this way. So that's really where the short-term counseling comes in. We connect clients to longer-term care solutions throughout the community. And we assist in integrated care with other IDC teams to make sure that we're taking care of all aspects of the residents and the client's needs. Disaster spiritual care is the third prong here in this IDC team, and they do spiritual follow-up and post-disaster care. It is non-denominational. We allow them to be able to express their needs spiritually, and our volunteers are all professionals in that arena as well. They will pray with clients. They will make sure if they need specific religious artifacts for themselves, if it's a Bible, if it's a prayer shawl, if it's a prayer mat, whichever, they make sure that those clients get those pieces of equipment. Okay, so the next question, how did the Red Cross provide ongoing IDC to clients in East Palestine throughout the spring of 2024? As I mentioned before, we were at the hearings. As you can see, that is an actual picture of the hearing. Our volunteers were amazing. They walked around with Red Cross branded. They wore vests, and people recognized that we were the Red Cross. And some of it was passive. We would just kind of walk around the room, and if we were seeing that folks were struggling, we would approach them and say hello, and can I offer you a bottle of water, and would you like a snack, and is there anything you'd like to talk about? So we made sure that they were present and we were available as folks were experiencing the hearings and as they were showing signs of distress. So connecting East Palestine community with resources, that was a big piece of this. We stayed in contact with the EMA. We stayed in contact with the NTSB. We worked with local organizations who could offer mental health assistance. We worked closely with the Salvation Army, which also came in and helped provide meals and other things that residents needed. So it was very, very important that we spent time working with the community, getting resources to the residents. One thing before we go to questions, one thing that happened while I was there, because I was physically there during those meetings, for each of those meetings, we made sure that the residents saw Red Cross, but we also tried to bring back the same Red Crossers each time, because quite frankly, they had a little bit of a fear of outsiders. This is a very small, tight-knit community. And the fact that it was the same people that kept coming back time after time, they recognized us, they thanked us, and they were like, oh, wait, you were here with the shelter. Oh, now you've been here at the last 3 meetings. So they started developing an affinity for us, and they started developing trust for us. So that was another really important piece of this, so that we could help support this community, was developing the trust with them. So at that's the presentation, and we're open for questions.
Right. Thank you so much, Emily and Barbara. I think that was really great to hear about your experiences and to let us know a little bit about what that was like to be involved in an actual on-the-ground incident, as well as how the Red Cross was able to assist both in the sheltering aspects of it, sort of that immediate aftermath role, and then also that more longer-term role there. I think that's a really great perspective there to sort of have as we enter sort of our discussion phase on the chemical disasters. So it looks like we have about a half an hour left, so I think we can start to go ahead and turn our attention to some of the audience Q&A for some of our panelists. So as a reminder, if you do have any questions, please feel free to put those in the Q&A feature. We will start to go through some of those and answer them as they come up. So just give a couple minutes for people to start putting questions in. I did see one here. Yeah, David, looks like you answered it in the chat for bringing up the behavioral health issues. I really like that both of your presentations really sort of touched on the sort of the dual sides of the coin, right? Of how behavioral health and physical health both go hand in hand, right? David, do you think you could talk a little bit about some of the elements of when you're doing that sort of decontamination process, that post-disaster process, some of the ways that you can think about keeping the mental health aspect in mind while you're also making sure that you're keeping the physical health aspects in mind?
Yeah, sure. So we have quite a large state-based hospital system. I've been involved in helping some of those hospitals to become prepared to do decontamination, particularly mass decontamination after chemical events. So some of the things which are commonly done, and I'll be honest, in the United States, you lead on this area, actually, are very well organized. Simple actions make a difference. So you would all be familiar with, signage, pre-preparing signage, for example, instructional materials in a variety of different languages and also different styles to match different, cognitive abilities, and also recognizing that people will be in a different mental state when they're coming through a process. So rather than making complexity, simplifying processes and being very clear and slowing things down in terms of communication to be both timely but just simple does definitely help. There's also a group of individuals who won't be able to use those resources. So having options and thinking that through is important. Some of the more recent interventions or actions that you can take involves getting people to use the devices that they'll come with some amazing devices, of course, iPhones, Android, whatever. So they'll have their personal devices, and you can set up QR code systems and almost have a web app that will help them through the process. So one idea is to become much more sort of individualized with your response. So have a mentor, like a on-app mentor, to step them through the process to reassure people. And there's like, rather than sort of stewing on what's happening to them as they wait, because there's a lot of waiting involved, there's a way for them to be able to indicate that there's a problem, maybe using the app, and that can then be coordinated more centrally. So some of the key issues with this mental health and managing mental health through these processes is dealing with the issue of delay and waiting and expectation, and having systems where people feel like they're actually engaged and connected. That we feel that is really a part of the solution. So that's one example. There's many other things that could be done, including improving communication, making sure people can see your face. This was done in COVID, where people put their photos on their PPE, for example, so that people feel connected. So it's the human touch, really. It's so simple, actually, when you think about it, but that's my experience. Yep.
Perfect. Thank you. Thank you, David. Continuing on the decontamination line of questioning here, Barbara and Emily, there's a question here that I think pertains to the events in East Palestine. Was there a decontamination process that people had to take part in individually or for their homes in East Palestine that you're aware of?
So there wasn't a decontamination process for the shelters at the time when people were coming in or the time when they were leaving. It wasn't considered to be that type of contaminant. There were specific houses that were within like a very close radius that could request help with cleaning of their property, but there was no formal decontamination process that was required or requested.
Gotcha. Was there a lot of questions about, I know you had talked about, what's going on, how long do we have to be here? Were there a lot of questions around, is my home okay? Is my property needs to be decontaminated? Were there a lot of questions like that?
Yes, a lot of questions surrounding that. As Barb mentioned, this is a very small town, a very tight-knit community. One of those towns where everyone knows everyone, right? And so it's, important to also put that into perspective that it wasn't a lot of people who had experience with something like this ever. And so it was really fortunate that they were doing town halls, they were doing updates where they were sharing that information, whether that was coming through public health, through emergency management, through the fire department. They did work hard as a community, as community leaders, to make sure they were aligned in their messaging of what they were sharing and what information they had from the East Palestine side of the house.
Mm-hmm. Right. So it's almost that lack of experience or lack of information around how do we deal with any kind of disaster on top of the technicalities around the chemical aspect of this disaster.
Yes.
Interesting. Great. Thank you. I think this is also for Emily and Barbara. Were there any issues with violence within the shelters? Who provides security for shelters? And is there any training regarding WPV for American Red Cross staff?
Yeah, so all great questions. So to answer the first question, we had no issues with violence in our shelter. In regard to security, we work closely with the public safety in that community. That is always our first go-to because, again, they know those people, right? The residents in our shelter know the people who support their community. And so if we feel like that's necessary or needed, then we will absolutely make sure that we have a 24/7 presence. Regardless, we do ask our community police whenever we're sheltering to make sure they're doing check-ins and checking in on the shelters and that things are going well and appropriately. I don't remember the last part of your question.
Is there any training regarding workplace violence for American Red Cross staff or volunteers?
There is. So all of our paid staff are required to take workplace harassment and prevention training every single fiscal year. So our fiscal year runs from July 1st through the end of June. That is also offered to volunteers should they be interested in taking it. It is not required for volunteers to take, but we also do a great job, I think, internally as a department to make sure that our volunteers understand workforce safety and they understand their roles and what the Red Cross policies are. So when you come in and you train to be a mass care shelter service associate, you will always be in a shelter with a mass care shelter supervisor who's more experienced, has more training surrounding Red Cross policy and procedure, as well as, you know, kind of going back to that mass care lead, right, that we used in this operation. We had even another level on top of that that was looking at some of those outlying factors to make sure we're setting all of our volunteers, but all of our residents up for success as well.
Perfect. Thank you. Going to the question sort of around the disaster mental health IDC support here. I know you had said there was about 2,000 evacuees. We're planning for about 10% of that. Were there about 200 people in the shelter?
So we actually had less than that. I think at our high capacity, we had about like 30 some. So for us in Northern Ohio, that was a large response at that time. We've had larger responses since then. But that was the dormitory of those who stayed overnight. We did have people that would come and go during the day. Obviously, they couldn't go back to their homes. They're staying somewhere else that's outside of an evacuation zone. But being able to allow people who were residents where they couldn't get back into their homes to come in and have a meal and check in with, you know, their neighbors who were staying there and those types of things is also something that we saw in regard to the number of people that were in and out.
Mm-hmm.
And also, Andrew, just real quick, also in the community meetings that they had, that was definitely a larger population of folks showed up there. We would see anywhere from 50 to 100. It was never huge, but they also, remember, they did multiple days at each time they came, multiple days of meetings. So a variety of people came to those meetings.
Yeah. Did you guys have enough IDC staff to meet that need, or did you have to bring folks in? I'm just thinking, like, I know our region here in New York, there's only a handful of us, and so I'm thinking about, you know, how you were able to look after your volunteers that way.
We were actually very lucky. We have a very close relationship with our partners in Pennsylvania. So the Red Cross in central Pennsylvania provided us with a couple of folks that we were able to have come over, and they actually came for each of those meetings as well. It was the same folks. So between our local volunteers and then a few volunteers over from the Pennsylvania area.
Oh, fantastic. Yeah, those mutual aid agreements are great for that. Yeah. Let's see, we have one more question here. I think this is regarding the East Palestine event. I understand there was some considerable false information and misinformation circulating during the incident. How did that impact on mental health services provided, and how is that addressed in a sheltering population environment in general?
Yeah, so I think when it comes to the sheltering population, what we were fortunate was that we were able to very early on set how, as Red Cross, we were going to share information and updates. So even though there was a lot of misinformation circulating, the residents that were staying in the Red Cross shelter were very well informed because of those community meetings and because of that AD of operations role that I talked about, who was attending those meetings and kind of going back to that mass care lead and saying, okay, here's the next update. Here's the newest piece of information. So although there was misinformation within the shelter, we were able to kind of keep that a little bit more under control, I would say. And then with mental health specifically, and Barb, you can chime in here too, because you were at the event specifically, but from what information I got back from our volunteers was that they were able really to because they're trained professionals, identify people in those situations when the meetings were in progress or when they're waiting for the meeting to start, to say, I can sense that this person is feeling anxious. I can sense this person, needs someone to talk to, and casually, be able to say, hey, how are you doing? And insert themselves into a conversation. And then if at that point they felt like somebody needed to talk, we had private rooms available to us to pull people out of that big space where there was a lot of people and a lot going on, where we could really have a one-on-one intentional conversation with someone and level in on, this information that you're telling me about is not accurate, or this information you're telling me about is accurate, and I understand why that's concerning you. Like Barb said, we're so fortunate here at the Red Cross to have amazing trained mental health professionals who are so good at being able to read people, but also read people and how they respond in a disaster situation. We have a course called Psychological First Aid that specifically talks about the psychological first aid response in disasters, right? How does it show up in a disaster, and how might someone look? What might they say? What might their body language be telling them, to really lean into that and be proactive versus just waiting to be responsive. Barb, anything else you would want to add to that?
Nope, I think that was great. The only other thing was that the NTSB was very, very good about squashing false information, at least during the hearings and when they came to their final fact finding. They were very, actually, to the point that they were stern about it. They made sure that false information that was floating around was addressed, and made sure that folks got the correct information in a timely fashion.
Yeah, that communication can be really important, right? There's actually just a comment here, not so much of a question, but more of a statement. Communication, honest communication is almost always the best route. I applaud you for doing that. I also wanted to ask Dr. Heslop, I know when we were talking about your research, it showed that communication or information was sort of the most needed thing from community members. Have you seen any in your research or anything like that about the role of misinformation and sort of how that can slot in there when there's not information being presented?
So I haven't come across instances of misinformation at the time of an incident that would be quite mischievous, I think, and of course have massive impact. So in that context, during an actual event where you're trying to help people, it's more disinformation or sort of a lack of understanding, or well-intentioned but misinformed individuals who think they know boats, so to speak, and start to do something wrong. For example, decontamination for certain substances can be spectacularly wrong if you choose the wrong approach. In fact, it can cause a lot of harm to do it the wrong way. And so if you make a mistake like that, you can end up causing problems rather than helping them. But so from a deliberate misinformation perspective, no, it's more a competence-related information during an event. After an event, yes, lots of misinformation, pointing fingers, political agendas, and so on. So that is something that we see here in Australia, people taking advantage of a situation for various means, and social media is very, everything that was just mentioned about the value of having a strong organization that can lead the way on dealing with misinformation is valuable. So we do, in our public response system, have within the operation centers, we've now got media teams that specifically deal with those issues and try to have a single point of truth. That's our approach. Yep.
Thank you. Let's see. Looks like the questions are starting to slow down. So if anybody does have any last questions, please feel free to put those in the Q&A. I did have a question here, actually. I'll ask Dr. Heslop, and then Emily and Barbara, if you guys want to chime in, please feel free. I was thinking about, when you were talking and sort of starting your presentation, talking about some of the unforeseen dangers here, I was reminded very saliently of public health disasters, right? Sort of the other one where the actual danger here is not very visible, right? Is there overlap between preparedness for CBRN events and preparedness for other types of disaster events? And are there some that are more, that preparedness maps onto better, for instance, public health disasters?
Just in relation to what I presented, I think that there's behavioural reaction to and a requirement for communication in almost every type of disaster, including sort of quite unusual sort of events. I think that wouldn't classify as a disaster traditionally, but are sort of societal upheavals, economic shocks, and so on, things like this. We've had to deal with that here in Australia, the mental health fallout of fairly significant events from time to time, which are not traditional disasters, so to speak. So I do think that the same rules do apply and the same observations do apply in my clinical experience and speaking with people who have managed the fallout from some of these other events. Yes, you know, we're talking sort of, you know, when people, groups of people might have we've had, for example, construction defect issues here in Sydney where whole buildings have been condemned and there's no recompense, for example, and we've had to deal with the clinical outcome of that for the residents, and it's just interestingly very similar kind of reactions, actually. So it seems to be consistent. Yeah.
Very interesting. Thank you. Barbara, Emily, anything you guys wanted to mention as far as the preparedness for chemical disasters, how that's any different than any other types, anything that you've learned from the experiences at East Palestine that you're thinking of doing things differently at Red Cross now, anything like that?
Yeah, so we actually in our region are surrounded by some nuclear power plants. So we do drills on an annual basis in regard to decontamination and what that would look like if there were an incident at one of these nuclear.
I think we're having trouble hearing you, Emily.
Oh. Maybe if I move back closer, is that better?
There we go.
Okay. So we have nuclear power plants in our region. So on an annual basis, we are practicing this with our volunteer workforce, with our communities, meaning that there was an event at a nuclear power plant that would require physical decontamination before people would enter a shelter. And so I think the difference for us and looking at that piece, because Red Cross, that is our main way when it comes to emergencies, we're being called upon generally for sheltering in those initial times, is that we do have to be aware of the decontamination process and how we do that and how we utilize it and how we practice that with our volunteers. So if it were to happen, that we are prepared and our volunteers know how it works to be able to be successful. I think the other piece in regard to just disasters with public health specifically is that if we see public health more involved generally, right? If there was some type of contaminant, whether it be in East Palestine or something that I just described, but also public health is involved when it comes to disasters at different levels, at least in our area of the state that we covered, dependent on what county you are in. Some public healths are in that forefront and that first grouping of people that are going to be part of that community response. Some of them are secondary or even tertiary, dependent on the level and how involved that they get. So we are well integrated with our public health teams, so we know where they fall in the fold, but we do have contacts that we can reach out to if we feel like, hey, this is a public health concern, whether it be in our shelter or it be something that we're hearing, so we can kind of pull them into the discussion if they're not already integrated already.
And to add on to that, we have national memorandums of understanding with the MRC, the Medical Reserve Corps. So if there is something that's impacting how we're responding in a disaster situation, and it also is a public health issue, we can work with the Medical Reserve Corps throughout the country to provide additional services.
Fantastic. Thank you, guys. So yeah, so it really sounds like C3, right? Communication, right? Getting everybody trained up to know what the procedures are. So Fantastic. I think that sort of brings it back full circle very, very nicely here. So anything else either of you three would like to say? Chrissy, anything else you wanted to chime in before we wrap up for the afternoon?
The only thing I would add from a Red Cross perspective is if you are an emergency management, somebody from emergency management on this call or somebody from public health, and you don't know who your Red Cross point of contact is, please go to www.redcross.org, put in your zip code, and click on the Contact Us button. There's always a regional executive or a regional disaster officer that's listed on those contact pages, and reach out to them and ask for a meeting. I know when I get emails like that, I get very excited to make a new connection and be able to meet a new face. And so I know that all the RDOs across the country, but I know we have a lot of people from New York here today, would love to hear from you.
Fantastic. Thank you so much, Emily, Barbara, and Dr. Heslop. Thank you, everybody, again for joining this webcast today. Again, presented by the New York State Department of Health and the Institute for Disaster Mental Health at SUNY New Paltz. And again, this webcast was recorded and will be available on the Department of Health Learning Management System for viewing shortly later this week. Thank you all again for coming, and I hope you all have a nice rest of your week. Thank you all. Take care.